The goal here is, next slide. And by the way, thanks to Rusty and Alex and all the Jedi Knights up there doing all the AV. Thank you very much. Can you guys see that? Okay, outline the pain pathway and its physiology. So we'll talk about a little bit of nerdy, dorky systems physiology, but we'll see why that matters, because we're going to build into that to talk about opiates. No problem with opiates. Oh, maybe there is. Let's talk about the drawbacks, and you can see it anatomically. Then we'll move on to, okay, so you don't like opiates. Well, what are you going to do for my patients? What are the alternatives? And then building upon that, if you are going to use opiates or other controlled substances, how do you do it well? Let's define the edges of the sandbox so that your patients can play in those boundaries and thrive. All right. What is pain? You really have to define it? Well, the International Association for the Study of Pain did. You can't read that. It says an unpleasant sensory and emotional experience associated with tissue damage. Is all pain associated with tissue damage? I heard a no. I had a patient come in and they held a book up, and I never met them before. They just said, "Hi, do you believe in this?" And there was one word across this little blue book. It's like a trick question. Because if I say, yes, I do believe in it, okay, then I need my morphine. If I say no, well, aren't you a doctor? Don't you believe in fibromyalgia? So there are things that we can't see or we can't understand, yet the pain does exist. And so here's some snippets, just statistics, don't even read them. But basically it says, why would you ever invent a fellowship of pain management? I mean, pain management as a fellowship's only been around since like 1990. We've had physicians and healers for ages. All of a sudden you decide that pain management's important lately? What's the deal? Well, it was based on fiscal issues, people losing lost days of work. And what's interesting is if you look at certain subpopulations, for example, some of this data from 2011, Native American back pain prevalence, different than other populations. So that there exists some variations in prevalence in certain subpopulations. All right, next. Okay, let's talk about the pain pathway. Let's say you're getting a total knee replacement and that scalpel's about to hit your skin. Or, like I did yesterday, got some wild rose on my elbow. Oh, lovely, that felt good. So you got a thorn. What is that pathway? Who cares? Well, let's build on that. So, here in the corner here is a little cross-section of our spinal cord. And there's a little filing cabinet there, the Rexed lamina. And so each of these areas in our spinal cord process different information. Pain, pressure, touch, temperature. Too cold can be painful. Too warm can be painful. Vibration. All of these things are processed. So if we have that event, like a stubbed toe or a big surgery, in comes the signal. Down this little telephone cord here, we call our primary sensory afferent. Those are all our sensory nerves. So here it comes, and we're basically taking this little area here and we're blowing it up so that you can see it. So this information goes through a series of interneurons, almost like a football that you toss to your neighbor. It's a handoff of signals. And the reason we talk about this is an area for the pharmaceutical reps when they visit your clinic. Modulation of signals. You ever heard of things called serotonin, norepinephrine? All of those medications that we use for depression, sometimes they can be used in pain because they modulate the pain signal. All right, so in comes the signal. There it goes up to the brain. Next slide. And here's a blow-up of the pain signal coming down the path. Here's the pain signal. We call it a C fiber. Pain signal comes down, and then you got this little canyon here. So the pain signal has to cross via neurotransmitter to the postsynaptic element. So it's almost like relaying the information to the next nerve. Who cares? Well, let's talk about it. So right now, this series of neurotransmitters, glutamate specifically, is going off right now. You're sitting down, your thighs are being compressed by the sea. Hopefully you're not in too much pain listening to me. This is just information that your body's getting. Yeah, my thighs are being compressed, life is good, no problem. So this is open. It's just background information. Notice this channel, think of it as a nightclub with a big bouncer. That bouncer is magnesium. There's a cover charge, you can't get in. So this channel is closed. This is the NMDA receptor, the N-methyl deaspartate channel. It's closed. This opens when? Next. In response to chronic pain. Chronic pain is defined as pain over 3, 4, 5, 6 months, lasting for a long period of time. This evil little neurotransmitter called substance P gets that bouncer out of the way, and you notice calcium comes in the cell. Okay, so back to our anatomy and physiology and all that dorky stuff that we had to know. The more positive the interior of the cell and the soul. The more positive the interior of the soul is, the more likely it is to depolarize and fire. So the more calcium and positives and all that stuff, the more likely you're going to get a pain signal. Okay, now chronic pain over time, more calcium, more calcium, more calcium, higher positivity, more depolarization. Ow, I hurt. Ow, I'm dying. 9 out of 10 pain. My hip is killing me. My back is killing me. So this is what happens, chronic pain. Okay, and as an anesthesiologist, if I come into the post-operative care unit and there's a patient there who's miserable, and ouch, I hurt, and here I come with my little syringe of morphine, right? And I give an opiate. How does that even work? Or a Percocet that you dispense in your clinic, or Norco, or Vicodin, or fentanyl, or methadone. What happens? How does the opiate work? What's the bottom line here? Well, essentially, the opiate sends a little eviction notice to potassium. It says, get out of my apartment. It kicks out potassium. The inside of the cell is less positive. It hyperpolarizes. It's more negative. The cell is quiet. The patient says, I love you so much. So, can you see how opiates would be terrific? I mean, I'm not seeing the problem. Looks good to me. Why don't we have a little jelly bean jar right there? We can all just have one. What's the downside? I'm not getting it. Okay, let's build on that. So that's how we normally process pain, and you can see the advantage of opiates. Okay, there's a problem with it. So let's talk about the physiology of opiates in chronic pain. There is something called the gate control theory. And what these two researchers tried to do about 50 years ago, Wall and Melzak, they tried to answer this question. How can two people with the same injury experience pain differently? I'm a 4 out of 10. Oh, I'm a 9.5 out of 10. How can that be? It's the same injury. So they tried to understand that. So if we look at our non-noxious information, this is information that is just non-painful. It comes through these A-beta sensory receptors, and it goes into, and it's hard to see, but this red guy here is the wide dynamic range neuron. Think of him as the judge. Think of her as the judge and jury. If she says yes, you get pain up to your brain. So this wide dynamic range neuron is sitting there right now, and it's deciding every second, should I fire and let him know, or let her know that I have pain? So the non-noxious information comes in and says, here's some information. But it also facilitates this interneuron here via GABA and glycine, which is a key little neuron, interneuron called the inhibitory interneuron. Look, got negative. So it basically tells this wide dynamic range neuron, the ultimate judge and jury, it's okay, calm down, don't fire, everything's okay. So right now you've got a positive 1 and a negative 1 equals 0. No pain signal. Now we come over here to chronic pain, and in the corner it's hard to see it, but it says pain fibers, C fibers, and A delta fibers. Not only does it say, hey, there's pain, here's a +1, look what it does here. Naughty, naughty. It inhibits the inhibitor. It says to this guy, go away. So if this guy can't fire, then you get ouch. That's what the pain receptors do. Okay, fine, yeah. What does that have to do with my clinic tomorrow? Let's see. Oh, by the way, now this was 1960, and now in the later decades we were able to find descending tracks from your brain to your spinal cord. And again, this is where the Cymbaltas and the effexors and the Selexas and all of those trade name stuff via serotonin and norepinephrine, they can actually attenuate the signal before it fires or reduce it. That's why sometimes in small doses we use antidepressants as pain medication, as alternatives to opiates. The tricyclics we've used for a long time for neuropathic pain, and also antidepressants such as Cymbalta, things of that sort. Duloxetine. Okay, next. Okay, opiate tolerance and opioid-induced hyperalgesia. So here comes the bad part. So far, it all seems good. All right, next. So here's what you know already. When you activate the receptor, it hyperpolarizes the cell. There's no action potential, pain relief. Life is terrific. But underneath the surface, you have an enzyme that's active that activates that NMDA receptor, causes sensitization in this thing called opioid-induced hyperalgesia. Now, where have we seen that NMDA guy before? We're back in that weird goofy slide, chronic pain, little magnesium bouncer, it opens up, NMDA activation. So what happens with opiates, next, is the same thing that happens with chronic pain. Here it says opiate receptors. You take medicines over a long period of time, it activates this enzyme, and boom, it opens this channel. But wait a minute. What happens with pain over a long period of time? It does the same thing. It hits this receptor activation. So you mean telling me, because I'm confused here, you mean you take opiates for a long period of time, and that's the same as chronic pain? Not following you. I thought opiates were for pain relief. They were originally for acute pain relief. Ow, I broke my ankle. Take some Norco, rest, relax, watch TV, crutches, comes off the crutches, you stabilize your ankle, off you go. No medicines, we're done. Over time, watch how your body outfoxes you. Calcium released, it initiates other enzymatic cascades with these protein kinase molecules. This kinase activates a proto-oncogene. Proto-oncogenes code for the cell to change its behavior. It's like going into the hard drive of your computer and actually changing it. What else happens? This kinase, we'll see on the next slide what happens. Nitric oxide synthase is released, that destroys DNA. Your body says, wait a minute, and it brings in this big, heavy crane, this large molecule called PARS. I'm still not getting how this is relevant to you tomorrow. Next slide. Well, because of this proto-oncogene coding for this oncogene, it alters your cell for further responses, so now you're sensitized as a chronic pain patient. So the same stimulus, ow, that really hurts. There's an uncoupling of that potassium receptor and the opioid receptor. Remember, it was the opiate's job to kick out that potassium, gave it its eviction papers. Well, potassium's not listening, so now you need even more officers to come to the residence to kick out potassium. That's why you need to take 1 Percocet in January, but 3 Percocet in June. You get tolerant. Further, you get some issues related to an inhibition of certain nerves. Now, if you go back to the gate control theory, there's where those awesome inhibitory interneurons in the middle of that little diagram that basically said to the dynamic range neuron, shh. Well, you can see in immunohistochemical staining with rats, chronic pain patients see, or chronic pain animal studies, you see those inhibitory neurons vanish. They become dark on the staining. They go away. So imagine now, you don't have any nerves in your body to attenuate the pain signal. So now everything's worse. So, okay, wrap this up in a little bow now. So, chronic pain patients have a cut that's this big. It actually feels like it's this big. Expansion of receptive fields, secondary sensitization. A stimulus that's actually kind of a 4 out of 10? No. It's an 8.5. Are you crazy? Give me my Percocet. This really hurts me. And the worst part about it is a non-noxious feeling, like shower water on their skin or a tissue paper, becomes painful. That's allodynia. Allodynia, not fun. So you can be skipping rope with a friend of yours. Both of you skin your knee. By the way, she's taking 5 Percocet a day. You're taking 0. You both skin your knee. Same injury. Everything's the same. Hey, how's your pain? Oh, yeah, it's annoying. It's like 2 out of 10. How's your pain? Percocet user. Are you kidding? This is 7.5 out of 10. Same injury. So you can see how over time your body says this. Oh, really? You want to make me numb? Oh, watch this. It wants to punch through the fog so that you can feel pain, keep you alive. Your body's pretty smart. So that's the downside of opiate use over time. is that you have a cascade of events that lead to more and more opiate use. Because after all, look, it worked in the beginning, led to tolerance. You get hyperalgesia, ouch, I hurt more, coming back to clinic. I know I'm taking 3 Norco a day, but that's not working. I need 4. Let's take more tolerance, more hyperalgesia. You mean to tell me that opiates cause pain? That's crazy. Well, I have a question for you. Any of your patients taking 6 Percocet a day experience 1 out of 10 pain? Aren't they all at 8.5, 9? Interesting. Okay, next. So, notwithstanding all of that, what about the office staff? I mean, if you dispense opiates, they got a pee and cup. What about the patient activity report through the DEA, the cures reports? You have to have clinic visits so that temporally it coincides with when they're due. What if they miss their visit? What are you going to do now? Sometimes it's a hot mess, yeah? It's hard. It's involved. Next. Okay, so multiple choice. Ready? Here we go. Didn't think you'd be tested. All right, let's see what we got. Okay, so you're in a clinic and this patient sits before you, wants to go up on Norco. Has that ever happened? Like every day. Not sure what to do here. So what's your goal with this opiate patient? Let's go multiple choice, Rusty. What do you say? A, get rid of all opiates. Bad opiate. Bad dog. Forget this. Like I did yesterday. Just grab the fishing rod. Forget all this. I'm out. I don't know. I don't know what to do here. Nervous about this. Patient sitting right in front of you. What are you supposed to do? You've just been told by the CDC that you're a felon and you better get that opiate down, right? Maybe Black Elk can help us. Next. So, hear me, 4 quarters of the world, a relative I am. Give me the strength to walk the soft earth, a relative to all that is. Not seeing the correlation between opiate use and this statement. You'll see what our goals are in pain management. Essentially is increased physical fitness, increased functioning. And so, like our ancestors before us, our goal is to increase our walking tolerance, our dancing, our singing, the things that bring us pleasure. You'll see in multidisciplinary pain management, that's the crux of how we can get people better, but also provide an alternative to opiates in chronic pain management. Next. Okay, so what is this pain management business? You don't need a pain management specialist. Do your stuff on your own. I can tell you that down in Ventura, where I'm at, the family practitioners send patients to me for multiple reasons. One is that they're too busy to provide alternatives to opiates. Number 2, it's a heck of a lot safer to just say, you deal with the morphine. I don't have time. And you don't. You guys are amazing. You're dealing with blood pressure and hypertension, all the social aspects, tobacco cessation, diabetes, monitoring their A1C, all of these things, and then right at the end of the visit is, oh, I need some opiate. It's very difficult for you. So the goal here when the fellowship was first introduced is to actually be a vehicle to take those medicines and then provide alternatives. Next. So this is how we look at pain management. That the patient's essentially in the middle of a big circle with me, and we're both watching college football. It's kind of like that type of camaraderie, where you're essentially on their team, not adversarial, but we're just kind of sitting together, saying, look, let's provide some alternatives. But we're going to go from conservative to aggressive to try to replace pain with life. So what's that? Prayer, exercise, coping skills, self-directed fitness, avoiding doctors, over-the-counter anti-inflammatories, water therapy, physical therapy, chiropractic, acupuncture. These cultures present today have an advantage over a lot where I am, because I can talk about the spirit world, and the patients through telemedicine up here in these other reservations, they say, I'm down. Sure, I'll do more of that. Other people, it's very defensive routine. What? Prayer? Yeah, right. So you have an advantage, definitely do. It's providing all of these conservative management options, and that's really what pain management is. We try to manage the opiates so that we can provide alternatives, and then we can see a nice taper or increase their quality of life. All right. And on that note, how do you measure whether they're better? Is it 1 out of 10? Is that physical function? Oh, I love you. So yeah. So 1 out of 10, what is that? 1 out of 10. I'm a 6 out of 10. What does that even mean? So there are some instruments that you can use, and in about 3 minutes you can figure out if somebody's getting better or not. The Oswestry Disability Index, O-D-I, internationally valid. It's all over the world. It's used. 10 questions. It's multiple choice, like our Norco party question. They can just mark A, B, C, D, or E, and ask questions like, how long can you walk? How long can you sit, stand? And you can get a number. It's scored out of 100. You can see 3 months later if you offer some type of therapy, whether by stepping in that variable, have you effected a reduction in their pain by increasing their physical function. So that's one, in addition to the 1 out of 10 numerical score. All right, next. What are your clinic's local options? So every time I meet a new Native American telemedicine clinic, I always ask, hey, so what's around? Oh yeah, we got Keogh Hot Springs down the road. Really? You have water? Kind of water therapy? Warm water-ish? Nice. So now I can offer warm water therapy, walking backwards in 2 or 3 feet of water for those patients who will never ever do physical therapy, much less even think about getting on a treadmill. Their hip hurts. But get them off the earth, put them on the moon, walk backwards in 2 or 3 feet of water. They get their heart rate up. You elicit aerobic adaptations. They get better sleep. Less anger. So these are the ways that we can find the local options to help get their pain lower. What are the local options? Now you guys should be thinking right now, what's around here? Do we have an acupuncturist? Yeah, but they don't take our insurance. Okay, is there any way you can have an accord with that person, increase their business as such, have them know that they're helping their community and offer it at a very affordable price? Physical therapy. If I had a nickel for every physical therapy prescription I've written, way better than seeing me, because it's those physical things that they can do at home in the comfort of their own home that can increase their aerobic adaptations, like I said, increase their exercise tolerance, which will reduce their A1C. You guys know that. It's a direct correlation. Next. So here's my mantra. It is not, we're going to put you on a diet plan for 4 weeks and I guarantee you're going to lose 20 pounds. I'm going to get you to run a 5K every other day and you're going to do it and that's how we're going to get you better. My goal is to make them all addicts. Full-blown addicts of what? Their me time for physical function. So you get their baseline walking tolerance. What's your walking tolerance? 2 minutes. From the chair to the bathroom and back. That's it. So that's okay. In August, it's going to be 3 minutes. So you're going to go from the chair to the bathroom, then go check the mail, and then come back and you're done. You're good. Wait a minute. That's not going to help them. What a joke. The goal is to get them used to the routine, like breakfast and breathing, such that by next Christmas it's going to be 19 minutes and they brought a friend with them. And now they can walk together because you can't have lunch with them right now. It's 12 o'clock, but you just got to wait. She's got her stupid routine. She's got to go take a walk. We got to wait till 12:30. It's just who you are. That's the kind of mantra you want to effect in patients, because in the end it's going to be them taking care of them, not you taking care of them overall. All right, next. This is not an opinion. This is not something that was just invented. This is fact. As childhood BMI goes up, adult heart disease goes up, it's a positive correlation. So these are things you deal with in primary care. Trying to get their BMI down, trying to make them more mobile. Next. How do we do that? Well, just look at your own community. Things that you could possibly do. Things they could possibly do. Small things. Hey, let's just fold clothes, put away the clothes. Let's fetch the paper, let's pick up the trash. Hey, I'm going to drive over to the hospice. I'm going to go move some equipment. I'm going down to the feed store. I'm going to get a 90-pound bag feed. I'm going to load up the finch sock for my little birdies. Fill them up, pick up some branches. So who cares? Little, meaningless, insignificant things like that. You can see the caloric expenditure of 318 calories. Next. I don't see a treadmill on here and a 10K, none of that, right? What's that? At 0.09 pounds of body weight, that would be 33 pounds lighter in 1 year, all things being even. Did I say to stop eating Snickers and Funyuns and have as many donuts? No. First, get the exercise. Those patients will select a 6-inch Subway club, right? Because they will, because the body will not be able to tolerate those kind of adaptations without good food, complex carbohydrates, protein, and so forth. So sometimes you can start with just the physical endeavor and then the the diet changes. All my dietitians are going, oh no, what are you doing? But you got to get them to believe in you, because this is normally, when we first start, it's like, I'm going to see who? Where's he from? So this is how telemedicine visits start, like this. You're not from here, right? Next. All right, so from a pain management specialist perspective, we go from conservative, like those things that now you're an experts in, the prayer, the exercise, the dancing, all of those things, and we migrate down that spectrum. And in Western medicine, this is also true. We start with the conservatives. There's something called spinal cord stimulation we can talk about. Opiates. Now opiates are considered higher. Before it used to be low, where you say, oh, your pain's hurting you, well, try some opiates. Oh, it doesn't work. Let's try some other things. Now we're seeing that the risk-benefit analysis is such where opiates are considered more aggressive and high risk. Right there with surgery. Okay, next. So our mission, vision, and goal for our clinic and clinics is to replace pain with life. Find something they like to do. I like to hunt. Well, my goal is to get you to hunt. I want to take care of my horses. Well, my goal is to get you to your horses. I want to be able to dance with my daughter at her wedding. Well, by golly, we're going to put that cane on the bench, and you're going to have a nice little corsage and a boutonniere. We're going to take nice pictures, and you're going to dance with your daughter. Everybody has these goals. All right, next. Okay, so in town, I hope there are some providers that can do this for you locally, because there are some pain states that are amenable to certain injections. And if we cool the area off, maybe it will decrease our need for medication. Yeah? Such as what? Well, here are a couple of common things you'll see all the time in your clinic. Next. All right. I have horrible pain. It goes in my back. It goes down my butt cheek. It goes into the outside of my thigh. It goes into the outside of my calf. Oh, sometimes it goes to the sole of my foot. Whew. It hurts when I rise out of the chair. It kind of like just goes all the way down. And it hurts when I rotate. It hurts when I move. Oh, but it's like zip and a zing, boom, all the way down. That is a left L5, lumbar radiculitis. That L5 nerve, as that exits the spinal cord, probably being compressed by a disc or bone. The nerve's mad at you. Think of a telephone booth. Nerve wants to be alone in that telephone booth, and now you put 6 other people in it. Gets mad at you. Sciatica. So you get numbness, you get tingling, you get weakness, you get pain. Where? Down the area where the nerve goes. So you can just Google L5 and you can say, oh, hey, look at that. So by listening and taking a thorough history, you can kind of correlate which nerve it is with where their symptoms are. Plus you get an MRI. So a lot of times I will say, hey, we need an MRI. That can help us confirm the diagnosis. So what I would do here is what's called an epidural. So you can see right here is a side view. You see a little needle here. This is the L5 vertebral body. This is the L4 vertebral body. In between is this invisible. That's the disc. So it's just like an Oreo cookie. Black cookie, cream filling. Well, sometimes the cream filling can push backwards. This is the little hole in the telephone booth where the nerve lives. And you can see an AP view. You can see some dark dye here. That's contrast, so we can see where we are. This is the L5 nerve root right there. What are we putting in there? Corticosteroid. So steroid is something your adrenal glands are churning out every day. All I'm doing is giving you an extra dose where? Right on that spot. Why do an epidural? Why don't you just cut them open? Take out a bunch of disc or a bunch of screws, make them Home Depot. Like, what are you messing with this for? Because if we can cool the area down, then they can go do your exercise plan. They can take care of themselves. You've got this therapeutic window where they can move more, walk more, sleep more, dance more. And then you interrupt that pain cycle. And they can say, you didn't cure me. This still hurts. It goes here, goes all the way down. Oh, but it's so much better. Oh, this is great. Can you walk more? Yeah. Because there are increases in physical function that will strengthen and tone the supporting muscle around there and maybe take some load off of that nerve. And think about it, if you can reduce weight, it's like taking a 30-pound backpack off of somebody. There is a direct correlation between back pain and your patients getting closer to their ideal body weight. It's a line. So if they're 100 pounds over, their pain is pretty up there. 90 pounds, 80, 70, 60, pain goes straight down. And you can take credit for it as a clinician, but it's all the patient, just doing what you told them to do. A little bit more walking, a little bit more dancing, and off we go. That's an epidural. When would you send that to somebody maybe in the community that can do this under a fluoroscopy or x-ray? Pain that is more electrical in nature. You can lift their leg up and do a straight leg raise, and it's positive. You can actually feel it. in the back, in the lower extremity. The corollary in the upper extremity is sciatica, or what we call radiculitis in the upper extremity. And by raising our arm, tilting their head sideways, you can actually facilitate nerve pain that goes down maybe C6, which is 6-shooter, these two nerves, C7, C8. These are things that can really impair people to do their job. Keyboard, sitting forward, sometimes they get radicular complaints like that. By inhibiting the signal or putting a fire extinguisher on the fire, we can then correct their posture and get their ear lined up on their neck so they're not forward. And then all of a sudden they feel a lot better. They're able to go through their whole 8 hours at their desk job. I put this up here on purpose to show that low back pain isn't just low back pain. Low back pain can be secondary to a host of issues. It can be from discs being compressed, because discs have nerve endings. It can be from facets, and that's what this is. Facets are little joints like knees that allow you to rotate and spin. They're just like a finger or any other joint. So if you have patients that hate to stand, and it's worse when they lean back, and then you have them load their, no, rotation-related pain, those are the facets grinding on each other. One more, Rusty, I'm going to show you. It's right here in blue. There you go. That's the facet joint. And they just slide on each other like tectonic plates. But as time goes on, with 1 g of gravity, look, we're standing up. Facets can get degenerated. They can get osteoarthritic. Dogs don't get it, we do. So we're straight up and down. So what's a good recipe for this? Like I said, take them off the earth, put them on the moon. Get them in some water. They don't have to swim. They can just do some activities where they're a little bit more buoyant. It's terrific, especially for that suspicious patient. You can start them on the moon, and then you can transition to land-based physical therapy. Yeah? All right. Next. In the neck, even if people have already had a fusion, there are patients that have headache pain that go up the back of their head, or they have pain right on the side here. It just kills them, and it refers out to their shoulder. This is referral pain that comes from the facets in the neck. Why do I mention these two things of all the diagnoses? Because it's super common in chronic pain, and it's the reason why a lot of your patients may be taking opiates. Axial spine pain, like neck pain and back pain from facets, and also the nerve root pain that goes down. If we find the right spot, there is something called, this is a facet block where we actually block those areas. We give patients a little scorecard, we have them document their pain before, and then after. So it's kind of a little Sherlock Holmes where we can kind of investigate and see if we can block the pain areas. Okay. If we're successful, we can use something called radio frequency, where we can actually lesion that nerve. We can send it to Honolulu. Bye. 80 degrees Celsius, 80 seconds, we can burn it. It's a pure sensory nerve, we can say goodbye to it. So it's a way to make the pain relief last a lot longer. It's called a radio frequency. It's only done after we do the test drive, do the facet block, and see if they say happy. If they say no, it didn't change anything, then we don't go to part 2, which is the radio frequency. So this is what we do in pain to prevent people from having to get cut open, having to go to Reno or go down to LA and get big surgery done. Next. What are other things that you might see in your charts that maybe some pain doc somewhere did, or things that can be done? There's a whole bunch. This is just a small menu. Epidural medial branch blocks, that's back branches. An SI joint, your SI joint is right here in the top of your tush. So patients that have impaired walking tolerance, they also don't like to sit on hard stone benches. And if you do this, a Faber test, Faber flex, abduct, external rotation, just say, hey, sit like a guy, don't sit like a lady, sit like this. That hurts the SI joint and the hip joint. And so sometimes that's a good telltale sign that their joint, which is just a big joint in their top, their buns there, their SI joint, that can be injected. It's easy, it takes a minute, 2 minutes, simple. Other nerve blocks for neuropathic pain. There are patients in this community that have neuropathic pain, horrible electrical shooting pain. There are blocks, you can take care of that. All the way down to your basic joint blocks and things like that. And finally, there's something called spinal cord stimulation. Next. Okay, spinal cord stimulation, not sure what it is, sounds awful, I don't understand it. What is it, some implanted thing? Ew. And that's the first response you get from patients, which is good. You introduce them to something and say, here's the literature, nothing fancy, here are the facts. This is what this thing is, and they say, no thanks. I say, perfect. As long as you give people options. And essentially that's all I am. I'm like a waiter at Shat's Bakery. Do you want shepherd's bread? What would you like? You're like a waiter. You give them options and they can say, no, 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 ew, no. Yeah, no, I'll try that. Okay, fine. So you step in these options and you put them in control. The reason I like spinal cord stimulation is it's one of the few surgeries that we have that you can test drive a car. People live with pain for 15, 20 years. I say, you have 7 days, try this thingy out. Even if you love it, it's coming out. It's an implanted device in the epidural space, but it's not implanted first. What happens first is you can test it for a week, see if it works. Even if it works and they're crying tears of joy, and I've seen it like, oh my God, this takes care of my back, it takes care of my leg pain, it's unbelievable. Say, it's coming out, it's just like an epidural, fancy epidural. But the implantation is a device. It looks like a little battery, like a pacemaker. It's usually implanted on top of the butt cheek, and the leads are in the mid-back. So I have a Navy SEAL with one. I have a 22-year-old from University of Colorado that Rose. So it comes in all shapes and all sizes. It prevents big surgeries and allows them to come off opiates. Love that. Or let's be real, some people don't come off, but their total dose is reduced. Next. It's hard to see. This is a X-ray of the mid-back. And right here, these little ants, that's the catheter. It's tiny. It looks like a piece of angel hair pasta. It's nothing. There's platinum and iridium on the tip. What the patient does, and they're awake, it's just a little epidural. It's a 5-10 minute procedure. We are mapping where the pain areas are, almost like we're fishing for a trout, the bottom of the lake, we don't know where it is, and we're reeling and we're searching for where the area is. And for some reason, there's an electrical stimulation that covers the area, and for some reason, I don't know, I never felt it, it's pleasurable. And it's really FDA approved for intractable pain of the trunk, that's the back, and the lower extremities. And for some reason, in some patients, just coats the area and cools it down. Well, you don't have spinal cord stimulation locally. No, but there are people in Palmdale that do it. There are people out of state in Reno that do it. So for certain patients, it's a blessing. They've already had a laminectomy. They've already had a fusion. You're worried about their opiates, their MME or 90 morphine equivalents. What are you going to do? Give them more? You're not allowed to. Or you're scared. They want to go up. They're miserable. The meds don't even work anyway. So what do? This is one thing that you can do. Spinal cord stimulation. Next. And this is when we talk about the Oswestry disability score. For me, facts don't have feelings. I want to know plain speaks. Does a thing work or not? So here's pre-Oswestry. The higher you are towards 100, the worse your disability is. And this is post. So a 10-point drop is statistically significant. I love this. This person can walk more, can sleep more, can do more things. Walking tolerance before stimulation and after. It's not a marathon, but look, out to 2 years, it's increased from 11 to 32 minutes. I love that stuff. Because that's real plain speak. Does the thing work, and does it work for a long period of time? Next. The reason I like it also is because it's easy, people are compliant, it's easy to have it done, it's not a big drama, it's not some horrible big giant surgery. And this is just another little caveat. Don't even think about stimulation after this, just if you hear about it and you want to know what it is, that's what it is. Can't read this, but I'll read this. There was this guy here named Stan. He was 83 years old. His wife was suffering from a terminal condition in the ICU. So every day he would go to the ICU and dote on his darling wife. In the bed next door was a man that was sick, and his wife would come to visit him. So Stan got to know the wife of that man, and they would go to the cafeteria together, and they would commiserate. There's a couple of great 80-year-olds. Flash forward 6 months, Stan's wife passes. He gets a knock on the door. Wonder who it is. So let's go back in Stan's history. He had a prostate surgery, a TURP, but there's lots of nerves around that prostate that can actually hurt certain areas. So poor Stan could never sit. He had something called proctalgia fugax, horrible pain in the groin. Couldn't do anything. Taking Norco, upwards to 4 tablets a day, even higher before. So I said, look, Stan, you want to try this device? You can try this device, whatever, I don't even know if it's going to work. He tries the stimulator, it works, he has it implanted. It's completely patient controlled. So, knock, 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 it was the lady in the hospital. So Stan writes me this letter. Is this a great country? How blessed am I to live in this medical age? People guess my age at 63 instead of 83. I'm beginning to accept it, believe it. But, this lovemaking is hell on the lower back. I increased the stimulation. What a big help. But I have 2 options. Option 1. Stop the lovemaking and take 1 Norco for pain. You used to take a boatload. Or option 2, take 2 Norco and continue the lovemaking. So, The reality is, patient's still on opiates, you see? But these little things like this, you watch out. You may be accused of having 80-year-old people have wild, crazy sex. So you're gonna do opiates. Okay, let's do it the right way. Is there a right way? Every clinic has their little ways they do it differently. But let's just go through a little bit and you can say, we don't do that. Doesn't have to be the same way, but let's just talk about some stuff. Okay. Go ahead, Rusty. There we go. Urine toxicology. You can't just do the little dip, 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 dip. You gotta have it sent out. You gotta do the mass spectrometry or gas chromatography. You gotta really see what's in the urine, okay? You wanna make sure that what you're giving them is there, and also that stuff that should not be there is not there, okay? Patient activity report. This is free. You just get the little facts, yeah? As clinicians, a lot of times your life is too busy. That should be devoted to somebody in the back office who can just run these out. Just everybody that's in your clinic, boom, just fax them out. You don't have time to go online as a provider. This should be done by your back office to increase and facilitate flow. Enforcement of offenders. You can't just say, it's okay, you're out early, you're good, it's okay. Take care. No, here's an early script. It's okay. What are you gonna do the next time? What's gonna happen? There it goes. So you have to have enforcement for offenders. You gotta have some bottom line in place. Next. The World Health Organization, we started on the first rung of the ladder. What do you give before opiates? The World Health Organization, first. Next. Good old-fashioned anti-inflammatories, or these over-the-counter things you can get at Dwayne's. Anything, patches, transdermal, Salonpas, ice, heat, good old-fashioned ibuprofen over-the-counter, provided they can take it, and you can offer them the risks and benefits to anti-inflammatories. So this is number one. Voltaren gel, these things, fine. Okay, that doesn't work. They're already on an anti-inflammatory. Okay, fine, next. Step two. Non-opiates, the gabapentins, great for neuropathic pain. Now you know, because you guys are all experts in the pain pathway, you can see how tricyclics and small doses of antidepressants sometimes can modulate the pain pathway, and it can give them a greater sense of well-being, but can also fight pain. And pregabalin, which is Lyrica, duloxetine, corticosteroids in small doses, can't be on that chronically. Next. Okay, now we're in opiate land. Now there's a whole bunch of other things that we haven't talked about in terms of medicine, so this is by far not a comprehensive list. Go ahead. Here we go. Muscle relaxants. You like these? Soma's awesome. Try to take it away from one of your patients. So, is there a muscle relaxant on that list? Well, yeah, I listed them all. No, wait a minute. Does Soma relax muscle? Your patients say they do. What? Flexeril? Scalaxin, Robaxin? None of them relax muscle. They're just a margarita for your head, just a day spa. The only thing that really relaxes muscle is what we give my cerebral palsy patients is backlift. Actually facilitates decreases in tone at the motor end plate, backlift. Patients aren't gonna like it because don't feel good, doc. What about benzos? You give them out to relax them? What about for sleep? The worst thing you can do for a patient for sleep is to give them a benzo. It interrupts deep stage REM sleep, stage 4 sleep. Oh, but it gets them to sleep, but it's shallow, non-productive sleep. The next day they're miserable, and now they're dependent on that. I don't write for benzos ever. I'd rather somebody was on Percocet. So be careful with your Valium and your Xanax, the #1 drug of abuse. Single women, mid-40s. I'm a TRICARE provider, I'm a military provider. I see a lot of vets, their dependents, active duty. The #1 drug of abuse, Xanax. Really? Yep. Come on, dad's away, got 3 kids at home on base. I need a little margarita. Xanax, a little white wine with it, why not? It's true. Careful with your benzos. Next. So if you're gonna write for short-acting opiates, how do you do it? Don't just give them Norco. Here you go, number 100. Take one every 3 hours. Enjoy. Make it simple. Make it in multiples of 30. So that if you're gonna give them one, give them one. See you next month. I mean, if you really don't trust them for the month, why are you giving them opiates? They're done. Forget it. Give them a month. Make sure their next visit is before they're due. They have to show up. We'll talk about that. But if you're gonna give them one, It would be Norco 5/325, number 30, 1 POQ day. PRN max 1 a day. Give them the boundaries. Give them their sandbox so they can play in it. And then they say, okay, 1 a day is not going to do it. Well, whatever you decide. If it's 2, it's 60. If it's 3, it's 90. And then you say to them, so how many are you going to take per day? And they say, 3. And you say, no, 0. You take 0 per day up to the max. It's 0. So some days are 0, some days are 1/2 of 1, some days are 1, crappy days are 2, the really bad days are 3. And look, they come back and they go, look, I've got 21 of them left. Your job isn't to take those opiates away, because what you've just done is you've given them control. They have a reserve. Control. So instead of you having a dog leash around your neck, like you're their steward, they're now in control of them. When you have a patient like that, your first impetus isn't to go to 0. This is a person that's thriving. The amount of stability you should have on a clinic visit with a patient is inversely proportional to how much time you spend talking about opiates. So if you have a 15-minute visit, and all 15 minutes talking about, oh, but my morphine's 15 milligrams, I'd like to have it 30. I really, really would like to have it at 30. Can I have it at 30? All 15-minute visits, I'm worried. But if I talk to my farm guy, George, and I said, so you did your harvest? How did the apples come out? Oh, they did good. I still had my cane, and I flipped them over. Boy, my back killed me. Hey, so what are you going to do next week? Oh, I'm going to the flea market. We're going to bring some stuff. Hey, take care, George. Oh, I forgot. Do you need Norco? I don't know. I might. Yeah, maybe I might. It's just like a side order of French fries. It's not on the forefront of their mind. That's somebody that I want to embrace. If they need that opiate, by God, take it and run with it. Because they're always on time. There's no DEA issues. They're not getting it from multiple providers. They have a reserve. Off we go. That's a person that you would give opiates to, particularly if you're seeing the ODI reductions in disability. Next. Now, after that, there are the long-actings. The crock pot that you put on simmer. A breakthrough, like a Norco or a Vicodin or a hydromorphone or a morphine immediate release, is for a fire extinguisher. Patients that have chronic pain, lupus, things that are ongoing. That's the crock pot. That would be methadone. Why methadone? I thought that was for heroin. Methadone hits that NMDA receptor, that evil one I was talking about. It's the only opiate that does that. Or a fentanyl patch, or a long-acting morphine. It is much better to have somebody on an extended release that they take exactly on the dose every single day, every 12 hours, exact. Doesn't matter if it's snowing outside, doesn't matter what's going on. It's 7 a.m., 7 p.m. So it gives them a steady depot of medicine, so they're not going and having a bunch of peanuts and having 17 Norco a day. That's much more stable. It's long-acting. When you write that, you don't put PRN, you say it's 2 per day. MSER, 15 milligrams, number 60, 1 POQ, 12 hours, 2 per day. So that there's a stable depot of medicine. If you're gonna go that route, do it right. The wrong way is a ton of short-acting. But if that's how you want to do it, that's fine. You didn't think about it like that, did you? See, we're not trying to have people have this sine wave where their pharmacokinetics go up Percocet, whee, down, trough, withdrawal. Up Percocet, whee, down, trough, withdrawal. If you're going to do it, have something with a long half-life. Yeah? Okay, next. Suboxone, awesome, MAT, right? Partial agonist, partial antagonist. These patients can be addiction patients, out of my scope. I can't deal with addiction, it's mostly pain management. A lot of patients are, I had a total hip replacement. My doctor put me on 4 Percocet. I'm having a heck of a time coming off of it. It's just harder than I thought. Well, you take the Percocet off, you induce Suboxone, and then you can sunset the Suboxone. That works very well. There's also another subset of patients who say, look, I have some pain. I'm a prior heroin addict. I'm not going back there, doc. I'm also a recovering alcoholic, whatever it is, I'm not going there. Suboxone is a mediocre pain reliever, so you can use it as a pain reliever. It's not great, but you can say, hey man, this is all you got, and Tylenol, and prayer, and acupuncture, and Tai Chi, and yoga, and all that good stuff. And a lot of them say, I'll take it. Very stable. There's films and tabs. You guys probably talked about this at MAT. Yeah? Suboxone. Okay, next. Here's some recipes for disaster in closing. Patients that say, hey, I need super high short-acting opiates. It's the only thing I need. Oh, I need the liquid. Seriously, the elixir's great. I need that. Oh, I'm out, by the way. Oh, you're not due till next week. Hey, I'm out. I was really hurting. What do you say to a patient that says, I was really hurting? So I took more. That doesn't exist, right? Because you say to them, I love you and I care about you, but I want to be a good steward of you. So being a good steward of you is gold medal. Your pain is officially now silver medal. So guess what? You're going to withdraw. Wait, what? You can't have patients withdraw. Really? You're going to see the cycle repeat. Recipes for disaster. So don't dispense these high-dose guys. Benzos. Gotta have soma. No directions on how to take opiates. Just here's a script. See ya. Gotta have a follow-up if you give them opiates. And it's gotta be within that refill window, mathematically. So they can never be out. It's impossible for them to be out if you put max 3 a day. How could they be out? Their prescription says 90 days. Or sorry, from the 30 days, there's 90. And they're coming back on day 28, they're good to go. But how can you be out? You can't be out. So they urine test now, not every quarter. Now it's autopilot. It's every month until they behave. Another back office thing. Urine. You don't tell people they have to have urine every quarter. You just put it on there. So you guys don't have to remember to do it. It's done for you as a provider. You're too busy. Defers other options. Hey, what about prayer? What about exercise? What about coping skills? No, I'm not doing any of that stuff. No, I didn't go to my physical therapy appointment. I need my Norco. You ever had that? I see a lot of nods. Like, getting tired. All right, what do you do with that? They refuse all these ancillary activities. They even miss the telemedicine pain appointment. Oh, here's your Norco. Really? Don't be a sheep. Be a shepherd. Say no. You need to have a little to say no. Nope, not going to happen. Next time you got to go. And hopefully they don't like you. That's what you pray and hope for. Because that's when you initiate the change. Right? That's change management. Because you love them and care for them. So don't enable them. Missed appointments. I missed it. I need my medicine now, damn it. Bam, on the table. You're the front office receptionist. How you feeling now? Feel a little worried? Feel a little uncomfortable? Should you be put through that? Law enforcement, zero tolerance for violence. Call them. That's it. Come on over. That ends. Yeah. Don't be. I've seen this. I've heard it. Don't get sucked into that. That person needs to be let go. Well, we don't let go people here. I'm not saying let go. They'll always be part of our family, but the opiate window's shut. They'll always be our brother and sister. Next. Here's a bunch of pharmacists. Here's a bunch of AMs, alprazolam, temazepam, a little buprenorphine as a side order. Oh, here's a little Percocet here. A little cough syrup, kind of for dessert. Bunch of different physician numbers. That's the patient activity report. Yeah, patients, too bad they missed out on you being their provider for opiates. They fooled you for a month. So don't let this happen over and over again. You got to pull these reports. They're free. Next. Urine toxicology. A little cocaine. What? I'm not taking it now. Or the best is, I'll retest for you. This isn't a test, spelling test. That's it. So you can't give opiates if they're taking illicit substances. Okay? You can do a 3 strikes kind of thing, like if you're given a Norco and they got Percocet from their dentist and they didn't tell you. So you can put a little asterisk in your chart like I do, like a baseball umpire. 1. Okay? 3 strikes. Or you can just, it's up to you guys. But don't go through the cycle. They can't do it. Okay? All right. With time remaining, next slide. Basically, we can talk about this after, but have you ever seen any of this? Patient ran out of meds, lost, need it now. What do you do with that? There's the protocol. It's easy. Don't think. I got it all framed out for you. Easy peasy. Positive urine tox for other medicines. What do you do with that? There's a formula. You don't have to think. You don't have to be the bad dog. In fact, if you don't want to be the bad dog, send them to that jerk down in Ventura on telemedicine, and I'll be the hammer man. That way you guys will be the nice guys, and I'll be the bad guy. But there really is a way to do this. Positive urine tox for illicit substance. What do? You can't continue to write opiates for those people. Tough love. Next, multiple doctors and patient activity report. What do you do there? Pretty obvious. A little phone call too to those other providers might help you as well. Or in the same clinic, you have a locums who writes for 8 Norco, and you got a PA that's timid that won't do 1 tramadol every eclipse. So if I'm, you know, Oscar the opiate hound, where am I going to go? Locums. Why not? Can't have that. You guys have to have universal protocols that you're all aligned. Yeah. Violent aggressive patient, you know what to do there. Patient defers alternative treatments. The opiates are with those complementary alternatives. It's contingent upon engaging in those activities that you set. You can't just sort of not go. And word will get around a small town. You got to do the right thing. If you love your patient, you got to serve them well and give them that tough love, which is to not let don't enable them to have bad behavior. Next. So in summary, this is the fifth hole, by the way. In summary, there's a lot of things to talk about. I just wanted you to be exposed on pain management, what it is. So whether you work here or work wherever, we can have alternative to opiates, and we can actually facilitate healing in our community. Next. And the goal really is to replace pain with life. Thank you.